Good morning, good afternoon, good evening. First, I would like to thank the organizers of the ALAT conference for the opportunity to talk about STACCATO ALPRAZOLAM in this virtual meeting today. This is my disclaimer slide. STACCATO ALPRAZOLAM is in development for acute treatment of seizures and is not currently approved in any region of the world for clinical use. I am an employee of Engage Therapeutics, which is now a fully owned subsidiary of UC Pharma since early June this year. This slide shows the STACCATO device inhaler on the left-hand side. There's a metal platform inside a plastic container. The active drug substance sits on the metal platform, and inhalation through normal breath activates the heating mechanism, which vaporizes the active drug in less than 1/5 of a second. Inhalation takes it to the deep lung, where it's rapidly absorbed for systemic delivery. Alprazolam is a well-characterized benzodiazepine that has been used for treatment of anxiety disorders for years. And on the other hand, the anti-seizure properties of benzodiazepines are well characterized as a class effect. Although alprazolam has never been used in the treatment of seizures before STACCATO ALPRAZOLAM clinical program. We have now completed 2 studies confirming the anti-seizure properties of STACCATO ALPRAZOLAM. The first study was a phase 2A study in patients with photosensitive epilepsy using the intermittent phonic stimulation model as a proof of concept. The primary endpoint was reduction in the standardized photosensitivity range, and the study showed quick onset of efficacy at 2 minutes, which was the first evaluation time point, and maintenance of the effect up to 6 hours, which was the last time point of evaluation with higher doses 1 and 2 milligrams of STACCATO ALPRAZOLAM. The phase 2B study was the second epilepsy study with STACCATO ALPRAZOLAM. It was conducted in patients with predictable pattern of seizures, and it was an inpatient study. It was the first study where STACCATO ALPRAZOLAM was dosed during an active seizure episode. The next steps of the program will be a phase 3 study in an outpatient setting treating predictable pattern of seizures. And after that, of course, open label extension safety study is needed to evaluate the safety of repeated dosing of multiple seizure episodes in an outpatient setting. The phase 2B study that I will be describing in detail with the following slides was unique in design, and it was the first study where STACCATO ALPRAZOLAM was dosed during an acute seizure episode. Therefore, we wanted to first complete the feasibility evaluation in an open label fashion in 8 patients before continuing to the double-blind part of the study. The open label feasibility study was successfully completed in 2018, showing that dosing was feasible, all the study procedures were feasible during and after a seizure episode. And we launched the double-blind part of the study in January 2019. Adult patients with epilepsy were eligible for the study, provided that they had frequent predictable seizure episodes. The patients were randomized to one of the 2 active doses of STACCATO ALPRAZOLAM or STACCATO placebo, and 1 episode was dosed in an inpatient unit. The treatment was self-administered if feasible, or it was administered by a staff caregiver if self-administration was not possible. And it was administered at the onset of seizure activity. After the dosing, patients were observed by a staff caregiver, and the events were also captured on video EEG. The adult patients with epilepsy were eligible if they had one of the 3 predefined predictable seizure episodes First one was generalized seizure episode starting with a flurry of absence seizures with a minimum duration of 5 minutes. The second one was episodes of a prolonged focal seizure with a minimum duration of 3 minutes. And the third one was episodes of multiple seizures in a rapidly cycling fashion within a 2-hour time period. Prior to randomization in the inpatient unit, patients must have experienced on an average weekly episodes of predictable seizure patterns. This is a schematic presentation of the double-blind part of the study. After screening, the patients were evaluated for eligibility by the Epilepsy Study Consortium, and after the Epilepsy Study Consortium had approved the seizure type, patients entered a qualification period for at least 4 weeks to confirm that they had weekly episodes. After qualification, the patients entered the EMU or CRU for randomization and treatment. On day 1, they were randomized to one of the 2 doses of STACCATO ALPRAZOLAM or STACCATO placebo. They stayed in the unit up to 8 days, and 1 predictable seizure episode was treated. The study drug treatment was administered at the onset of the PSP. After the treatment, the patients were followed up for 24 hours for efficacy and safety evaluation. The primary endpoint of the study was proportion of responders. The responder was defined as a patient who achieved seizure activity cessation within 2 minutes of treatment and no recurrence within the subsequent 2 hours. This table shows the demographic characteristics of the patients in the study, showing that there were no major differences in these characteristics between the treatment arms. Eventually, 116 patients were randomized and dosed in the double-blind part of the study. 40 patients were randomized to placebo, and 38 patients to STACCATO ALPRAZOLAM 1 and 2 milligrams each. The mean age of the patients was a bit more than 30 years. More than half of the patients were female subjects, and the mean duration of epilepsy in these refractory patients was more than 20 years. The predictable seizure types were evenly distributed between the treatment arms, rapidly cycling clusters being the most common predictable seizure type, followed by prolonged focal seizures. The patients were on chronic background AEDs, lamotrigine, levetiracetam, lacosamide being among the most commonly used. And the patients were also allowed to be on background chronic benzos for epilepsy treatment, but the use of benzodiazepines was kept to 35% of the patients, and the randomization was stratified by the use of benzodiazepines. This slide shows the epilepsy characteristics of the participants, showing that the study population nicely represented general epilepsy population, with approximately 2/3 of the patients having focal epilepsy, most commonly temporal or frontal lobe epilepsy, and about 1/3 of the patients had generalized epilepsies, either idiopathic or symptomatic generalized. Both Lennox-Gastaut syndrome and other symptomatic generalized epilepsies were represented among the patients. This slide shows the efficacy by the primary endpoint, showing nice effect with both 1 and 2 milligram doses of STACCATO ALPRAZOLAM, with a responder rate of 65.8% with each of them, compared to 42.5% with placebo, yielding an effect size of 23.3%, which was statistically significant. The effect was rapid in patients who received active treatment. As you can see on the right-hand side, the mean time to seizure cessation in responders who received active drug was less than 34 seconds. STACCATO ALPRAZOLAM 2 milligram dose reduced the recurrence of seizures up to 6 hours compared to placebo. This slide shows the Kaplan-Meier curve with median time to next seizure event showing that it was delayed with 2 milligram dose compared to placebo, even though the difference was not quite statistically significant. This slide or table summarizes the AEs reported across the different treatment arms. Cough and somnolence were the most common AEs, with STACCATO ALPRAZOLAM reported by 14.5% each. Cough was more common with 2 milligram dose than 1 milligram dose of STACCATO ALPRAZOLAM. The cough AEs were graded as mild in 10 out of 11 subjects, and one case was graded as moderate. None of these cough AEs were associated with other respiratory AEs or changes in vital signs. Somnolence was more common with 1 milligram than 2 milligram dose of STACCATO ALPRAZOLAM, and again most of these cases were graded as mild, a couple of them as moderate. Dysgeusia, strange taste in mouth, was reported by 10 subjects with active drug and 1 patient on placebo. Dizziness, nausea, sedation, and throat irritation were all reported by a couple of subjects. Overall, the AEs were mostly mild or moderate in intensity, and there were no treatment-related serious or severe AEs reported. And this favorable safety profile and tolerability profile is consistent with previous studies with STACCATO ALPRAZOLAM. Sedation and somnolence were also associated using visual analog scale. This slide shows the VAS scores for different treatment groups at different time points. The first time point of evaluation was 10 minutes after dosing. VAS score of 100 is representing fully alertness, and a drop in the score implies that there was sedation in the patients. And as you can see, there was a drop implying somnolence in all the treatment arms at 10 minutes after dosing. And through the first 2 hours, the sedation was a bit more prominent with active drug than with placebo. After 2 hours, the sedation effect faded away, and there was no difference between active drug doses and placebo at 6 hours. PK samples were collected at 10 minutes after dosing and at several time points after that, up to 6 hours, to confirm successful delivery of the drug after STACCATO dosing during an acute seizure episode. And this slide shows the concentrations curves for 2 milligram dose and 1 milligram dose. There was a nice dose proportionality with STACCATO ALPRAZOLAM concentrations, and these levels are consistent with what has been perceived with STACCATO ALPRAZOLAM in previous studies, PK studies in healthy volunteers, where the Tmax has been 2 minutes or less when the PK samples have been collected early after dose. To conclude, in this phase 2b study, treatment with STACCATO ALPRAZOLAM was efficacious. Both doses, 1 and 2 milligram, resulted in a significantly greater proportion of responders than STACCATO placebo. Mean time to seizure cessation was short with active drug, supporting rapid systemic absorption and onset of clinical activity with STACCATO ALPRAZOLAM. Generally, STACCATO ALPRAZOLAM was well tolerated. The AEs were mostly mild or moderate in intensity, and no severe or serious treatment-related AEs were reported. And as discussed, this is consistent with prior trial experience with STACCATO ALPRAZOLAM. PK analysis showed successful dosing during a seizure episode. Active drug concentrations were achieved after dosing. To summarize, these results support the efficacy and safety of STACCATO ALPRAZOLAM in treating acute seizure episodes. and further studies are warranted. Thank you so much for your attention.
Thank you, Jouko.
Mayor.
Thank you very much for your elegant presentation. I have some questions for you. And the first one is from an old common friend of us, Emilio Peruca. He says, "Hi, Jouko, nice to see you again." And then he starts, "Can you explain to us why, for this innovative development, you selected alprazolam rather than other benzodiazepines for which we have greater experience in seizure therapies?" It's similar to the question I asked you 2 years ago in EILAT 14, why alprazolam?
Yeah, that's a great question. And of course, it's well known that benzodiazepines are efficacious for seizure treatment, and alprazolam has mainly been used for anxiety, not seizures. The selection was done by Alexa, who was
Yes, I remember
developing the device and technology. And I think the main reason was there were a couple of reasons. Of course, alprazolam needed to be some drug that could be used with the device. It needed to be compatible. That's one thing. But the second part is that they were initially thinking about or considering a program in anxiety, treating patients with panic attacks. So the device drug combination was available and was tested for epilepsy for those reasons.
Okay, I give you, Emilio Peruca usually asks in duplicate, so I'll give you his second question.
Okay.
Keeping the real-world scenario in mind, can you kindly discuss the potential concerns with inappropriate, especially suboptimal dosing due to inter- or intra-subject variability in inhalation efficiency?
Yeah, that's a great question again, and it's a combination of the dose and type of inhalation that is required for sufficient delivery of the drug. And it has been shown that normal breath activates the device and takes the drug to the deep lung for delivery. And it was one of the objectives of our phase 2b study was to look at the feasibility of dosing in different seizure scenarios, look at the efficacy and the PK exposure. And it was feasible across the different seizure types. And as I mentioned in one of my slides, 2/3 of the patients had focal seizures, 1/3 had generalized epilepsy. Majority of the patients with focal seizures had focal seizures with impaired awareness. And they were, when assisted by the caregiver, they were appropriately able to dose themselves and get the drug into the system.
I have another question to you from Bossa Jokic Jacobi. I think she's now in Kuwait or somewhere in the Persian Gulf. Regarding the effect of photosensitivity, did you control photoconvulsing response, i.e. clinical seizure, and also drug-suppressed photoproximal response, PPR? From her experience, photosensitivity is prominent in early adolescence at the age of 13 to 18 years. Therefore, did you plan study for that age group? Thank you.
So first of all, the intermittent photic stimulation model is a well-known proof of concept model for testing anti-epileptic drugs. And it requires patients who have a consistent pattern of photosensitivity responses after stimulation. That's why it was selected for the study, and it's not supposed to induce seizures, only epileptiform activity on the EEG. And the results were really nice, showing fast onset of action at 2 minutes and consistency of the response up to 6 hours with 1 and 2 milligram doses. So that's the IPS model part. As for the adolescent subjects, we haven't tested the drug in any subjects below age of 18 until today, but of course for the phase 3 plan, for the phase 3 study, there's a plan to go to younger age groups. at least into adolescence.
Thank you. I have a question from Tatiana Liakina. The question regarding administration. The patient is supposed to be fully preserved awareness to be able to use the device effectively. Is it so?
No, as I mentioned previously, more than half of the patients in our phase 2b study had seizures with impaired awareness. So if the patient is able to do so, they can put the device to their mouth and inhale deeply, and the drug is being delivered. If the patient is not fully cooperative, someone else, like caregiver, can put the device to their mouth, and once they inhale, it's delivered sufficiently to the deep lung and bloodstream and to the brain. It's a great question.
Thank you. Last question from the next speaker, Mike Rogowski. He says, what dose or doses do you plan to use in your phase 3? Because according to his opinion, the 2 milligrams seems to be reasonable, but would you use other doses?
I think the current plan is to go with 2. It has nice efficacy and it has some data suggests that it has prolonged efficacy beyond 2 hours.
Thank you, Jouko. Since we are over time, I would, on behalf of my co-chair and I would like to ask you to stay with us up till after Professor Rogowski lectures so we can have general discussion, because there were a couple of questions that have not been answered. So thank you very much.
Thank you, Mary.